Lovely. So it's 20 past. Hello. Thank you for joining us on this, where I am, bright and snowy Thursday afternoon in Yorkshire. But I see we have half of the world geographically joining us, which is wonderful to see. Those of you who have been working with combat for some time will know that the first question you get asked by the doctors is often, how do you perform against the gold standard treatment? Why should we use this instead of BCG? And we have had numerous small studies, pilots, posters, podium presentations performed in the past. However, we now have a full paper published by one of our oldest friends in Spain, Felix, who will talk to you in a moment. Just to say that this is being recorded and will be available on our YouTube channel. Later today, we will send out to all of the participants not only a copy of the paper, but also a link to listen to my ramblings and then the important stuff from Felix after that. So with no further ado, he says, pausing once more to let Christine back in, I will hand you over to Felix. Felix is the Chief of the Department of Urology at 12 Octubre Hospital in Madrid and a Professor of Urology, as you can see there, the San Pablo University in Madrid, and an old friend of combat with whom we are very proud to present our first fully published trial in high-risk patients. So Felix, over to you.
Hi, thank you everybody for joining. Good afternoon. First of all, I'm not the chief of the uro-oncology of the urology department at 12 Octubre. I'm a member of the uro-oncology unit.
I promoted you. I've promoted you, Felix.
I don't think so. I don't think I want that. Okay, so we're going to speak about our recently published paper on our randomized clinical trial in high-risk BCG in high-risk non-muscle invasive bladder cancer, comparing BCG with mitomycin C in hyperthemia with HIVEC. So first of all, these are my disclosures and some relevant remarks for this paper. This clinical trial was funded by Combat Medical for all the financial and logistic support so that we could carry out the trial. If we look at mitomycin C, she's an old friend of ours and has been used in neurology for a long time. And the basic mechanism of action of mitomycin C is the cross-link in DNA strings, both intra and interstring. Also, if we look at hyperthermia, and we'll see it later, hyperthermia has multiple ways of mechanism of action directly on the cells, also activating some immune cells like T cells or NK cells, and also there are some other effects that may enhance the absorption of certain substances due to an increase in the blood flow, due to an increased perfusion through the membranes of through the mucosa. Particularly in the bladder, the first report speaking about hyperthermia for bladder cancer was published in 1974. And you can see how doing an irrigation with a hot saline in the bladder, you can see that there was in 19 patients from all the series they report here, more than a 50% decrease in the size of the number of tumors in the bladder. So this is officially the first report of the effect of hyperthermia in bladder cancer. Also, and not so much time ago, in 2004, in European Urology, it was published the synergy between mitomycin C and hyperthermia. As you can see in cell cultures, if you if you use mitomycin and at different target temperatures from 37 degrees centigrade to 43, and now we'll see how this device gets 43 degrees centigrade, you can see that the surviving proportion of cells is much lower when you use high temperatures. Since then, the effect of hyperthermia has been widely investigated on the urothelium, and the main reasons are the cytoskeletal changes that increase the permeability of the molecules you're putting into the bladder. There's also a decrease in the viscosity of the urine due to the high temperature, and this increases and facilitates the substance penetration throughout the bladder mucosa. There's also a decrease in the intracellular volume. So if once the cells are smaller, all the intercell unions are altered, and there's more a way for the drug to penetrate through the mucosa. And there's also, as a direct effect of the hyperthermia, the inactivation of certain detoxification mechanisms inherent in these cells. So there's different techniques to administrate hyperthermia. There are two different groups, mainly the AMDA, which is based on electrical flow, and the thermochemotherapy, and this is where we are going to be centered. For thermochemotherapy, there are three ways of reaching the thermochemotherapy inside the bladder. One of them is the local regional hyperthermia, which is not being currently used due to the big devices. This is a machine like a CT scan, so this is not useful for an everyday practice. And the two more popular are Synergo, which is a microwave-induced hyperthermia. It's the same way of working as our microwave in our kitchens. And the other one is the recirculant hyperthermia, which is the HIVEC Combat BRS device, and it is the one we use in our center and the one we use for our trial. Now we'll see deeply how it works. With respect to HIVEC bladder recirculation system, which stands for BRS, in Spain, it's started commercialization in 2014, and it's a recirculating system with an aluminum heat exchanger. As you can see, through this three-way catheter, we have the mitomycin in the system, diluted in saline, and this goes into the bladder and goes out through the catheter, and in the aluminum exchanger, we get the target temperature to have into the bladder the temperature we need. This warranties mitomycin at a target temperature of 43 minus or plus 0.5 degrees Celsius. And as I told you before, we use a three-way 16 carrier catheter, and the flow rate is 200 millimeters per minute. The advantages mainly of this device are the ease of use, the size of the device, which is not very big, and it can be fully transported from one to another place. With this device, Duke University and the group, Brand Timmans group, published some time ago how you get the target temperature in the bladder and how this is safe for adjacent structures. So you can see that the target temperature in the bladder will be around 43 degrees Celsius, as I said before, and this is the outer wall of the bladder, which barely gets over 40 degrees centigrade, and this is the rectal temperature, which is at 39.5 degrees centigrade. After 15 minutes of the hyperthermia, we see that most of the temperatures get back to the normal ranges. So to put in context the study and why we did this trial, we know that the main features of high-risk non-muscle invasive bladder cancer are the recurrence and progression rates. Recurrence can reach 60 to 80% of the patients at 5 years, depending on the series you are reading and depending on the treatments administered. And progression can reach almost half of the patients at 5 years. The standard of care for this population has been BCG since the publication of the EORTC trials comparing BCG with normothermic or room temperature mitomycin, but BCG is not without toxicity and has several issues. The main issue currently is the lack of the drug. As of 2012, we've been experiencing several BCG shortages all over the world, and we've had to look for alternatives. There's also a lack of efficacy in certain patients who will not respond to BCG and whose prognosis is quite poor. And currently, the most effective alternative for these patients is a radical cystectomy, which, as we all know, is a surgery not without complications and certain mortality, depending on the series, 3 to 8% in the first 90 days. Also, BCG is associated with significant toxicity, 63% local side effects, and 1/3 of the patients will suffer from systemic side effects as the effect of the BCG vaccination. So our aim in this context was to compare BCG versus mitomycin, hyperthermic mitomycin, with the Hivec BRS device in these high-risk non-muscle invasive bladder cancer patients. We did this trial being designed as a pilot phase 2 randomized clinical trial, including all high-risk non-muscle invasive bladder cancer patients according to the EAU guidelines 2016, which has been the same classification until until 2020. This was designed during one of the first periods of BCG shortage in 2014-2016, and here you can see the design of the trial. Patients with TURBT and optional postoperative single installation who were classified as high risk according to the old classification, which is any T1, any high grade, or any recurrent more than 3 tumors, more than 3 centimeters, TAG2, and excluding CIS. We'll see later why we excluded CIS. So these high-risk patients were randomized to receive either the control arm with BCG or chemohyperthermia with Hivec 40 milligrams. This is the schedule of the treatment. BCG was administered for 1 year only due to the shortage. According to the SWOG schedule, this is 6 weekly induction institution plus maintenance consisting of 3 weeks at 3, 6, and 12 months. Hivec consisted with a 6 weekly induction period as BCG, and then maintenance was done at 6 monthly installations to complete a total of 8 months. The main the outcomes of the study was a recurrence and progression-free survival at 2 years, and also cancer-specific survival, and of course being a phase 2 trial analyzing safety, although this device had already a CE mark and was approved for use in the European Union for patients. We used 50 milligrams of oncotized strain for the BCG treatment, and 40 milligrams of mitomycin C diluted in 40 milliliters of distilled water. The recirculation time was 60 minutes at the flow rate I said before of 200 milliliters per minute. Target temperature was the standard for this device, which is 43 minus plus 0.5 degrees Celsius. Follow-up of these patients was done according and following the EAU guidelines for high-risk patients. This is cystoscopy and cytology every 3 months, CT urography at diagnosis, and then yearly or if clinically indicated, and TURBT if suspected recurrence in these patients. If we look at our consort diagram, we see that 50 patients were randomized, 25 to each of the arms, and there are 2 populations for the study of the efficacy: the intention to treat analysis, where every patient gets in, of course, and then the per protocol analysis, which was defined as those patients who had received at least the induction period in any of the arms. So patients who were not included in the per protocol analysis. As you can see, 25 patients per arm in the intention to treat analysis, 22 patients in the per protocol analysis for the mitomycin arm, and 21 in the per protocol for the BCG arm. Those are the patients who completed at least the induction period. And this is why some of the patients did not receive the induction period, and this you can find it on the supplementary material of the paper. If we go to the results, you can see that the the population of our trial is a typical bladder cancer population with a mean age of almost 74 years old. Most of the patients were male, almost 90%, and with a median follow-up of 34 months, we found 11 recurrences and 7 progressions. From the 11 there are 11 recurrences, from which 7 progressions. From these 11 recurrences, 7 were in the BCG group, 4 in the HIVEC group, and from the progressions, 6 were in the BCG patients, and 1 progression happened in the HIVEC patients. There were 11 deaths in our series, only 2 of them bladder cancer related. In the baseline characteristics, and we'll see it later, as you can see, there is certain homogeneity between tumor size, number of tumors, and so on. There's only certain increased number of patients with prior intravesical therapy failure in the BCG group, and this we will comment it in the discussion. Regarding the efficacy outcomes, this is the intention to treat a population, which is all the patients, any randomized patient. We see that a 2-year recurrence-free survival is 86.5% in the HIVEC group versus 72% in the BCG group. And if we go to the progression-free survival at 2 years, 95% of the patients in the HIVEC group were free of progression at 2 years, and 71.8% in the BCG group were free of progression. In the per protocol analysis, these data are obviously improved because this includes all the patients who received, as I said, at least 6 instillations of the assigned allocated treatment. No differences between cancer-specific and overall survival at 2 years, and there's an increased cystectomy rate in the BCG arm, probably due to the more progression events occurred in this arm. There was also a trend towards higher time to recurrence in the HIVEC arm with 21.5 months versus 60 months in the BCG group, but this was not statistically significant. Where we did find a statistical significance was in the Kaplan-Meier survival curves for progression. We can see that there was a statistically significant difference in favor to HIVEC regarding progression-free survival, and there was some difference in the recurrence-free survival that, however, did not reach the statistical significance. Regarding the adverse events, and being this clinical trial, every adverse event was documented and reported. And we can see that within the trial, 65% of the patients reported at least 1 adverse event. As you know, in trials, anything that happens to the patient, even if it's not related with the treatment, is an adverse event. But if we look only at therapy-related adverse events, 48% of the patients reported at least 1 therapy-related adverse event. There were only 2 severe adverse events, which were grade 4 or 5, both in patients receiving BCG. And you can see here the distribution, and the most common adverse events for BCG, grade 3 BCG, were fever. And for HIVEC, the most common adverse event was grade 1-2, a bladder spasm during the instillation of the mitomycin. You can see also in the supplementary material, every adverse event happened to every of the patients, and what happened with this adverse event. Of course, we're not going to go through this table right now. So to sum up and to see the context where our paper is published, If we look at other recent experiences which have been reported with HIVEC-MMC C, there's a paper in urologic oncology from the group of Greenberg where they only include a single arm with 14 patients of intermediate and high risk according to the AUA guidelines of 6 weekly instillations, only like an induction period, but the dose of mitomycin was higher and at a higher concentration. Remember, we had 40 milligrams in 40 milliliters. This is 120 milligrams in 60 milliliters. 60 minutes recirculating and 1 extra hour in the bladder before removing the catheter. With this different scheme and only 14 patients in a single arm trial, we see that when 1 year recurrence-free survival is around 80% for these patients. And we can also see that most of the adverse events are similar to the ones in our series. Bladder spasm and an increased mitomycin allergy may be due to this increased either concentration or dose of mitomycin in these patients with HIVEC-MMC. I said we excluded our patients with CIS from this trial. This is for 2 main reasons. CIS is not as frequent as papillary tumors, and having a small sample, as we had of 50 patients, maybe CIS couldn't be representative, and we couldn't withdraw any conclusions, including these CIS patients, that would alter our cohort. So we decided to exclude them on the basis of this. And also, we have seen later that from the HIME trial by Tang in European Urology, those patients in this paper, in this trial, patients who had recurred after BCG therapy were allocated to a control arm, which could consist in a BCG reinduction or retry with BCG, or the local the investigator's choice versus hyperthermia with radiofrequency induced hyperthermia. So in all the patients, we can see that there are similar disease-free survival rates between both of the treatments, either the re-challenge with BCG or investigator choice versus radiofrequency induced hyperthermia. But if we compare, we see that those patients with CIS do much worse with hyperthermia comparing with most of the control trial, which was BCG or investigator's choice. So this is one of the reasons why we think we did well in excluding CIS patients from our trial. Also, we discussed about the BCG unresponsive population. As you know, the FDA is accepting any trial, single arm trial, for the BCG unresponsive population. This is a difficult to treat population. They usually have a cystectomy as the only alternative. And if you do not perform a cystectomy, any other treatment has a very low success in these patients. So using HIVEC in this BCG unresponsive population is an option in some centers. And there's a recently published paper from Peepers and Hugh Mustafid, where they analyzed their 56 patients retrospectively treated with HIVEC-MMC who are BCG unresponsive, and they can find that they have, with the limitations of a retrospective study, 1 year high-grade recurrence-free survival of 53% and 2 year high-grade recurrence-free survival of 35%. However, this data coming from retrospective series should be confirmed prospectively, and then this could be seen as an option for a BCG unresponsive population, where most of the new molecules are being tried right now. You can see also that those patients with CIS have worse outcomes, like in most of the cases, and those patients also, there's a difference between BCG refractory and BCG relapse. This is a recurrence after an initial BCG response. We know these patients have a better prognosis, and that also happens, or there's a trend for this happening both in CIS and BCG definition in this series, though not reaching statistical significance, probably due to the small sample size. Our limitations is that we have a phase 2 pilot trial. This is not a phase 3 big randomized trial. However, recurrence-free survival was set as the primary outcome due to the need we had in that moment for alternatives to BCG. Usually, phase 2 trials have as a primary outcome safety outcomes, but this was approved by the ethics committees and the Spanish Medicines Agency, as we needed to have a clue on the efficacy outcomes of mitomycin with HIVEC to compare them to BCG and to have an alternative to BCG in certain cases. Derived from the design of the trial, we have a small sample size, which is only 50 patients, and also in the BCG arm, as I said at the beginning when I was speaking about the baseline characteristics of our series, we see that there were 5 patients who had failed previous intravesical treatments in the BCG arm versus 2 in the HIVEC arm. So this could reflect that there were some worse patients in the BCG arm who had already tried some previous therapy. The conclusions, and this is the conclusion you can read in the paper, the end of the movie, that HIVEC or trial compared HIVEC and BCG in patients with high-risk papillary non-muscle invasive bladder cancer, excluding pure CIS or concomitant CIS. So the results we have suggest that HIVEC with mitomycin provides comparable safety and efficacy to BCG, and is of course a reasonable alternative that we could consider during BCG shortages, and we can also consider it in those patients who have a contraindication or BCG intolerance as an alternative before bigger things like cystectomy. Of course, a larger trial should be performed to determine whether HIVEC is superior to BCG in this population. I would like to give special thanks to the patients and relatives who have participated in this study, to all our nurses and personnel and residents and the rest of the urology department who has been collaborating in our trial, to Dr. Villacampa. We worked together until 2018, then he moved to another center, and he was one of the people who had the idea to perform this trial when we had the problems with the BCG. Maripaz Martin, who is our study coordinator, and without her, we couldn't do any of the trials we performed. And of course, last but not least, many thanks to Combat Medical for their support for the trial and the machines and everything we need whenever we need them. And thank you everybody for your attention. We can discuss anything you like now.
Wonderful. Thank you, Felix. Thank you for your kind words about us and others, and for the insight into what you've been doing in your center, which is being replicated in daily practice in real-world evidence around the world, I think. We have a couple of questions that have already come in. Regarding questions, the chat is open, everybody, so if you want to put stuff into the chat, you can. If you would rather speak, even if only to stop me from speaking, if you press the reactions button at the top, you can raise your hand. I don't think you need to raise your hand if you need the toilet, but you can raise your hand and then I will unmute you and we can hear your beautiful mellifluous tones. Raina asked about CIS patients, which you covered off, I think, with regard to the poor result that was obtained with the HIM trial. I think I am commercially mandated to say that this was, of course, using a different method of heating the bladder than we use. But we do understand, of course, that these patients are.
Yeah, you're right. But when we designed the trial, we didn't have the results of the HIM trial. Of course, there's a different method, but the main reason when we did it is that CIS would be a small proportion. We wouldn't know the impact of this, maybe 2-3 patients with CIS per arm. CIS has a standard treatment, which is BCG. Instillations for CIS are not the same as for papillary tumors. For papillary tumors, instillations are the adjuvant therapy. For CIS, instillations is the standard therapy, and TURBT is more like the diagnostic therapy method. So the main reason was this, and then when we saw the results of the HIVEC trial, of course, extrapolating of different populations who had already failed BCG, and a population using a different device, we think that we did well not including these patients, but we didn't know this when we designed the trial.
That's good. Sometimes you look back and you have been fortunate in the way you've designed the trial.
Yeah.
And sometimes there is the other side of the coin, but that's a different story,
Sure.
I guess, for today. And if I steal the screen just momentarily, the paper to which Felix referred from the Dutch group and from Hemostafid in the UK was this one. It's a retrospective analysis, but it was done on prospectively chosen patients, a prospective series. So there is some greater validity than just in a more general retrospective analysis. But this had a large CIS population. And as you can see, the recurrence-free survival was very high compared to some of the other, as Felix said, molecules that are available out there at the moment. The world is making a big fuss about nadofaragene and about pembrolizumab and about atezolizumab and about other things that I cannot pronounce and look more like a Wi-Fi password than a drug. But the FDA are currently asking for 30% recurrence-free survival at 6 months for a drug to be seen as efficacious and worthy of applying to the FDA. And as you can see, we have a bigger number. Now, of course, this trial comes with many caveats that it is largely retrospective, it's small, and it's other things, but it's encouraging. It's encouraging.
Just to add to that we will be releasing, publishing hopefully in the coming months, another series specifically on CIS group, which will actually be a larger group of about 58 patients and has a very similar complete response rate to what was shown there, but in a larger cohort of patients. So that will hopefully be of interest and hopefully provide evidence that even though Felix chose all the right reasons for not choosing CIS in this group in terms of actually focusing very specifically on papillary, is that hopefully that we'll be able to prove in time that we will be able to work in the CIS population as well. And we're also planning as a company a large phase 3 trial within that group that we hope to run and start in the coming year.
Cheers, boss. Thank you very much. These are the sort of figures that we're producing that the FDA consider to be worthy. So our FDA acceptance is in hand. So if any of you wealthy surgeons and distributors out there are looking for a good investment, Mr. Bruce White is available after the meeting. Other questions that were raised. Rainer again asked, what do you consider to be the optimum treatment protocol? I know the treatment protocol here was what we would call 6+6, 6 induction, 6 maintenance. I generally say at this point that medicine is a science. Urology seems to be a bit of an art. I'm an orthopedic surgeon by training, so that is neither a science nor an art. I think that's a sort of practical woodworking skill. But what is 6+6 enough, Felix? Should you do more? Should you do less? Where do you think on that?
Well, the only thing clear regarding schedules is that BCG should be performed according to the SWOG schedules, at least 1 year until 3 years. There is no consensus of the schedule we should use for chemotherapy, normothermic chemotherapy. When I talk to my colleagues from different centers, it's difficult to find a consensus and not everybody uses the same.
Yeah.
But we decided to use a 6-week induction period based like on this BCG and similar to the BCG, and trying to do a maintenance period with 6 monthly installations. This was some empirical thing, but As we saw, we published a paper in November, December 2021, 3 months ago, in the Hivec Hr paper in the Journal of Clinical Medicine. We see that there is we publish all the series of all the patients from Spain treated with in a multi-center study with Hivec mitomycin with different schedules, and we see that there was a difference in recurrence-free survival at the cutoff of 4 months. Those patients treated with at least 4 months of treatment had better efficacy outcomes than those patients. Generally, in our center for intermediate risk, we use 4+3, which is 4 months, 4 weekly plus 3 monthly. And in the high risk population as this, we use 6+6.
Yes, the EAU guidelines still continue to say that it is much debated, and that is pretty much the only opinion they get. But exactly as you spoke, in our larger analysis of the Spanish data that is captured through the registry, and there are many people on here probably who put patients into that, so thank you very much. This period of 4 months giving a increase, a palpable almost 20% increase in progression and recurrence-free survival does seem to be very important. Now, whether you do on behalf of our shareholders, 6 weekly plus 66 monthly sounds reasonable, but we have to think of what is practical within the patient population. So 6+6, 6+9, something that mimics the 1-year SWOG protocol does seem to be the right way to go.
Yeah, it's also one of the advantages if efficacy is similar. One of the advantages with this schedule we use is that treatment duration is shorter, because the total duration of the treatment with Hivec will be 8 months doing 6+6, and the total duration with BCG will be 1 year doing the 1-year swab scheme. I see here there's one patient collected who says he received 6+9. I mean, 6+9 mimics more the BCG schedule, because it's a total of 15 installations. I don't know whether or not that's better than 6+6. We don't know. Nobody can answer that question.
And we will never. There will never be the data to prove it, really, because to do a comparison of 6+9 versus 6+12 versus 6+4 sounds nice, but yes, I agree. Wonderful. The rumor, of course, was that they gave 15 BCG treatments to a patient because 15 BCG ampules came in a packet. But I'm sure our friends at SWOG would have a different opinion on that. Mr. Van Guts, we are joined by the head of MEDAC now. I might be promoting France as well, but only just. He asks about re-TUR. It's a pretty low re-TUR rate in this study, and we know that re-TUR has a positive impact on progression. Any comments around this?
Well, everybody knows the guidelines. Everybody knows that currently T1 is equal to re-TURBT according to the guidelines. But then when you speak to other people, we are a very high volume center. When I have spoken to other people, especially from Spain with other high volume centers, not everybody does re-TURBT to all T1 patients. So we do not do re-TURBT because some years ago, before designing this study, we did a study on our re-TURBTs, and we found some predictors of presence of tumor in the second TURBT. So we perform a TURBT according to our criteria. I know this is not the best because we're not doing what the guidelines say, but we're doing what our experience and what we have seen in our center, optimizing all the resources. So TURBT was performed in our patients for those, of course, with no muscle in the specimen, which wouldn't let you stage the tumor, would be a TX. Those patients with an incomplete resection, and those patients with a discordance between the endoscopic vision and the pathology. If the surgeon says it looks like a solid muscle invasive tumor, and then the pathology says that's the TA, for example. However, the good or bad impact of the absence of RT-RBT in our series would be the same for both groups, as the RT-RBT rate was similar for BCG and for HIVEC.
Yeah. Fine. Do you use any form of augmented visualization, either in this study or in your general practice? Are you using HEXVIX or something similar?
No, we just use our spectra or Clara Press Chroma or whatever we have stored equipment. So the similar to the MBI narrowband imaging from Olympus, we use our Spectra A or Spectra B from Stork for those patients, especially those with no clearly visible tumor, and to look for certain different areas to biopsy and to find if we have positive cytology without an evidence of bladder tumor in the cystoscopy.
No problem. NBI, I know, Spectra lesser. I hear that HEXVIX is wonderful, and this is unrelated to the fact that we have some Scandinavians on who I will now send my invoice to. But yes, the use is there. Okay, fine. Another sort of practical question: 60 minutes, half an hour, 45 minutes, as long as the patients can tolerate, keep it. We do it for an hour because we've always done it for an hour. 60 minutes, 30 minutes, what are your thoughts?
Well, I think the answer to this question is as difficult as the answer to the optimal regimen, optimal schedule. I think there was some data about that, like the most effect, like 85% or 90% of the absorption of mitomycin happened during the first 30 minutes. So why prolonging that? You could optimize your resources, do more patients per morning. I don't know. We still do 40 milligrams in 40 milliliters in distilled water for 1 hour recirculating time, and that's how we do for intermediate or high-risk patients that receive this treatment.
Mm-hmm. I understand that there is a study shortly to be published which may have positive news around a shorter treatment time. I'd probably say, I can't say much more than that, but I think I've probably said enough. I mean, that goes to Andre's question that he's asked as well, that often, as you say, there's a practical consideration. It's a very busy department with busy nurses, and if you can do everybody for half an hour instead of an hour, it gets it done quicker. But watch this space, as Edward said on the CIS data. If you watch this space, you may see some interesting data on 30 minutes as well. David Woodcock, we have a patient on with us. We should all remember that this is not about the science. It's certainly not about the shareholders. It's about the patient. So it's always great to have a patient on. And he said that in the UK, they receive 6+9, which seems to be the standard in the UK. It's still a little bit variable, should we say, over here. But 6+6, 6+9, this seems something that's both practical and tolerable and efficacious. Wonderful. Any more questions from anybody else? Thank you, David, for your follow-up. Fingers crossed for your ongoing treatment. Any more questions?
There was also a question about any other drug using
yes,
apart from drug than mitomycin. We have not used them. We have only used mitomycin because we've also had in Spain and also in the rest of Europe mitomycin C shortages. We have shortages of everything now, gas, then I don't know, whatever. But when we had mitomycin C shortages, patients who were under HIVEC treatment or mitomycin for postoperative instillations was prioritized, and then we used epirubicin or gemcitabine for normothermic adjuvant treatment. So that's why we didn't get to try mitomycin, other drugs than mitomycin. But I know that there are certain people who have used gemcitabine or epirubicin, or even doxorubicin, I think, and I think tolerance and everything is similar. I cannot speak about that because I've not tried it and I've not read anything scientific about this.
We have well, the stage last year where we had both a BCG shortage and a mitomycin shortage, we were looking for papers on the power of prayer and its effect on high-risk bladder cancer. We are fortunate now that mitomycin has returned. BCG, certainly in the UK, is largely absent, but can change from one hospital 5 kilometers up the road from another one, and probably the same in Spain. We have some data on other drugs because regardless of the availability of mitomycin globally, there are certain territories. Obviously, we have some of our friends from Greece on board. I know that mitomycin is always an issue in Greece, and you may be able to get the 2 milligram version, which if you ask the pharmacist to make up into 40 mil for you, the pharmacist will hate you forever. But there are difficult issues about availability. We have a paper which people are, if they haven't seen, they can ask me for, I'll send out, from our Italian group on a single center study of his patients, again, retrospective. And his thoughts were that using epirubicin, the results were very similar to what we're seeing with other drugs. I think I might have I gone one screen too far? Bear with me. There's another paper from this one. Hang on. Maybe not. Sorry, bear with me. We have another paper on gemcitabine, but in general use rather than in specific use with our system. And again, it suggests that there is similar efficacy. We did some work with Brant Inman's group, again at Duke University in the US, looking at animal model increase of absorption of the different molecules, gemcitabine, epirubicin, doxorubicin, mitomycin. And in fact, the largest delta between normothermia and hyperthermia of absorption was for gemcitabine. Now, is that reasonable then to suggest that gemcitabine is a more absorbed and thus more efficacious drug for bladder cancer? Don't know. We will be doing a study. We were starting a study this year in Spain on gemcitabine use. So again, we are at the forefront of this. We are supporting studies to answer all of these questions that have never been answered historically.
I see people are saying that in the Netherlands, epirubicin has been used. I had that impression, that idea. And there's also somebody asking about when we do perform the first installation. This is variable. We try to be around 6 weeks. In the trial, we did it at 6 weeks after the TURBT, which is 40 days, something like that. We try to do it, as the guidelines say, at least after 2 weeks from the TURBT, the latest 8 weeks after the TURBT. So we usually operate on the patient. 2 or 3 weeks later, we see them in the office to see the pathology. Then we indicate what adjuvant treatment, and 2 or 3 weeks later, they start with the treatment.
Wonderful. One similar one to that, just because it's always asked in these discussions, immediate post-operative installation?
Excuse me?
Do you do an immediate post-operative installation?
Yes. Yes, we do it, but our protocol excludes patients, well, according to the guidelines, those patients with a history of high-grade tumor, those patients we exclude those patients with a positive preoperative cytology, those patients with like solid or muscle invasive cancer, and also those patients with we include those patients with a prior low recurrence rate less than 1 year, EORTC score less than 5.
Fine. And you're doing these hot or cold?
Cold.
Why?
We thought about doing it hot. We should try that. There's Ana Plata in Canarias in Spain doing the hot prenatal.
I'm just pulling the data here. With me, people are arriving a bit late to the party. Some people are dropping in. Hang on, I have to let those in as well. I can.
Yeah, I think we have here in the participants also Diego Carrion. Let me see if he's still here. Yeah, he's been doing this in La Paz also with hot preoperative.
Yes, so here,
if you want to say anything, Diego, you're more than welcome.
Here are Ana Plata's results. what she was doing, which was interesting, because the historic concern has been that if you have an undiagnosed perforation of the bladder and then you give actively circulated chemotherapy, although admittedly at a fairly low pressure, are you running a risk of extravesicular leak of the chemo? What Anna is doing is giving the immediate post-operative dose immediately, pre-operatively, with the thoughts that often logistically it's much easier to do, and those cells are still nice and full of mitomycin whilst you're operating, providing an unfriendly surface for re-implantation of excised cells. And of course, you get 100% in her study of the patients having this treatment, rather than only around 2/3 of patients having the IPOP, even though they were all consented to have it, just because it's difficult in theatre, you don't have time, the patient wants to go home, and so on. Any more for any more? Let me look at the chat. We're losing a few people. Generally, when I start talking, we lose about 30% of the participants, but that's not too bad. Thank you all. If there are no further questions, a wonderful point upon which to finish is that a patient advocate who is with us has been clear for 18 months. So thank you for you, sir, and good luck with the continuation of that. Thank you very much to Felix for all of the work he's done to get the paper, to get the patients done, to get the study done, to get the paper published, which was probably the hardest bit. With the reviewer number 3 would like to add this, to get, and of course for finding us an hour of his time today to come and present. And thank you to all my wonderful friends, our wonderful customers, colleagues and surgeons around the world for your continued work with Combat. The video of this will be available. I'll cut out most of my rubbish from the start, so it should only be about 45 minutes long, and we'll send that to all of the participants in the next day or so. Thank you all. I hope to see you all soon. Cheers. Thanks again, Felix.
Thank you, everybody.
Thank you very much. Cheers.
Thanks,
Bye.
everybody, for joining. Bye-bye.